Welcome to the USMLE channel, and this is the ICU series. In this series, I'm going to cover the most common cases you are going to encounter during your ICU rotation, during your internal medicine residency. I'm going to crack open these cases like never seen before. So let's begin. Alright guys, so now this brings us to the final section of this topic, which is going to be management. The management is very straightforward. There's only three parts of the story, guys. It is about IV fluids, IV insulin, and finally, is there a need for bicarbonate or not? That's it. Let's talk about each of them individually. Alright guys, so now let's talk about the most important step in management of patients with DKA and HHS, which is IV fluids. IV fluids is so important that certain literature actually says that giving IV fluids is even more important than giving patients insulin. And they even say that if you give the patient IV fluids, the IV fluid by itself can decrease glucose levels in the blood. And how does that happen? It's very interesting. Think about it. As I've already told you and explained to you, you guys already know that both DKA or HHS were volume depleted. So if I replace the volume, what's going to happen is you are going to get increased blood flow to the kidneys. So if I get increased blood flow to the kidneys, does that mean that I'm going to have improved GFR? Yes, I am, right? So if I improve my GFR, that means I'm going to wash out more glucose in the urine. Isn't that just beautiful? When you give the patient IV fluid when they are volume depleted in DKA and HHS, that by itself decreases your glucose level in the blood by about 50 to 70 milligram per deciliter per hour. Right? So this tells you that IV fluid is a very important part of management of DKA. So when talking about IV fluids, there's only three important things that you have to focus on. Number one is your sodium. Number two is your potassium. And number three is your glucose. Now before I come to this part, anybody with DKA or HHS, it does not matter what the sodium, potassium, glucose levels are. First off, anybody's coming with DKA or HHS, we are going to go straight ahead and give them a lot of boluses. Reason being, I already told you they are volume depleted. So first step is to give them boluses. Boluses of IV fluids. And which IV fluid is going to be the most isotonic and going to remain within the vessels is going to be your Ringer's lactate is the most isotonic. However, you can also use normal saline. So first off, I want to improve the volume status of this patient. So for that purpose, I have to use just normal saline or Ringer's lactate and volume expand them within the blood vessels. So you are going to give them about 15 to 20 milliliters per kilogram of body weight. So if somebody was say about 70 kilograms, you're going to give them almost 1.4 to 1.5 liters of fluid as just boluses. You're going to give them as boluses within the first few hours. I would give them 1, 2 or even 3 liters as needed to improve their volume status first. So once you've done that part and the patient's blood pressure is more or less better, the heart rate has gone down, now you're going to get to the maintenance section of your IV fluids. Now when you come to the maintenance section, there are some important parameters you must pay attention to. And what are these parameters? The way I see it is, think of it like you're making your patient a cocktail. Think of your IV bag as a cocktail. So you want to mix your cocktail. Now when you're mixing your cocktail or mixing your IV infusion, there's only three things that you could use to make this infusion. And that is sodium, potassium and glucose. You don't always have to use them. You could choose to use them if you want to use them. So what determines whether you're going to use them or not? So let's start with sodium. So when you look at sodium, you must use corrected serum sodium, guys. You cannot use the absolute value you're seeing in your complete metabolic panel. It must be corrected for your level of glucose. And the equation is as follows. For every 100 increment in your glucose, you must correct the serum sodium by adding 1.6 to your basic sodium level that you get on your CMP. So for instance, if somebody had a blood glucose level of 500, from 100 to 500 you have 400s. So for every 100 I must add 1.6 to my my serum sodium. So 1.6 times 4 is going to give me 6.4. So if my measured serum sodium level was 135, when I add this 6.4 to it, the corrected serum sodium must be 141.4. Alright, so once you have your serum corrected sodium levels, you are going to do the following. So for instance, if your corrected serum sodium level was less than 135, at this point you would just use normal saline. So into your cocktail, I'm going to throw normal saline in if the patient had a corrected serum sodium less than 135. That is the only time that you would use normal saline during your maintenance phase. If the patient's corrected serum sodium was greater than 135, may it be 140, 150, 160, I don't care. If the serum sodium is greater than 135, at that point you will use half normal saline. That's it. The story with your sodium is so simple, guys. If it is less than 135 is the only time that you would actually use normal saline. If the corrected serum sodium was greater than 135, at this point you will use half normal saline. Now remember, this theory does not apply to your first few hours. First few hours I will only use normal saline or Ringer's lactate. Remember, you're trying to expand volume intravascularly in the initial part, and the only ones who can actually do that very efficiently is isotonic fluid. So it must be normal saline or Ringer's lactate during your initial phase. However, during your maintenance phase, it all depends on your corrected serum sodium. Greater than 135, you will use half NS. If it is below 135, you will use normal saline. Alright, so let's move on to the potassium story. Now potassium, when we speak about potassium in patients with DKA and HHS, there's something very important you need to realize. Most patients who come with DKA, especially when compared to HHS, will have a very high potassium level in the blood. It might be 6.8, it might be 7, it even might be 8 sometimes. But this does not mean that the patient is having hyperkalemia within the entire body. There is hyperkalemia in the blood because this potassium was spilled out from within the cells. I want to ask you guys a question. Do you guys remember what is your most important intracellular ion? It is potassium, right? So think about it. If a patient has diabetic ketoacidosis and your blood is acidic, what your cells are going to do is it is going to take up this H+ ions, therefore to try to reduce the acidity, but the only way it could do that is by in exchange for potassium. So in a person who's DKA, you'll have significant acidosis, so your body's compensatory mechanism is actually take up the H+ and spill out the potassium into your blood. So what has happened now is you've washed out all the potassium within your cells. However, you are seeing it as hyperkalemia in your blood. Another reason why you're actually potassium depleted within your entire body, including in patients with HHS, because HHS patient did not have the acidosis factor, right? The reason there was because of volume depletion, activation of your RAS, and eventually activation of your aldosterone pathway and causing potassium secretion in your urine. So this is important to realize. So potassium is so important for us in our fluid mixture. When you're making your cocktail, you need to throw in some potassium if you need to. So what determines this? So remember, your upper limit of normal potassium is greater than 5.3. If your blood potassium level is greater than 5.3, at this point you do not have to add potassium to your fluid yet. But the moment your potassium level reaches the upper limit of normal, the moment it touches 5.3, okay, the upper limit of normal is 5.3, the lower limit of normal is 3.3. The moment it touches the upper limit of normal, you must add potassium to your fluid, guys. This is by far the most important step you must remember. The moment potassium touches the upper limit of normal, you must add potassium to your fluid. So in your cocktail mixture, it might be normal saline or half NS, and now if your potassium level touches the upper limit of normal, which is 5.3, so between 5.3 to 3.3, you must add potassium to your fluid. Alright, so now another final important point about your potassium. I said between 3.3 to 5.3, which is normal, you will add potassium to your fluid. What happens when your potassium drops below 3.3? Guys, what is the only contraindication to using IV insulin or any form of insulin in a patient with DKA? It is a potassium less than 3.3. The moment your potassium gets below 3.3, you must stop your insulin drip. It is so important. Reason is this, guys. Insulin actually stimulates the uptake of potassium into the cells. So if your potassium level has reached the lower limit of normal, which is 3.3, at this point, I don't care what's going on. You run to your patient and you immediately stop your insulin drip. That is the first step you have to do when your potassium reaches 3.3. guys. All right. Apart from that, once you stop the insulin drip, you must immediately replace potassium in a very aggressive way in your patient and recheck it within an hour or two to make sure your potassium has now normalized. One of the most important reasons why a patient actually dies, goes into cardiac arrest in patient with DKA or HHS is in fact hypokalemia. So potassium, low potassium, less than 3.3, stop your insulin drip immediately and replace potassium aggressively. Perfect. So you guys understood your sodium story and your potassium story. Now finally, your last and your third component is going to be your glucose. Now glucose in patients with DKA and HHS. So normally if you have a patient with DKA and HHS, you know that these patients are going to have very high blood glucose levels. So normally you're not going to add glucose to your fluid. However, the important endpoint of managing DKA and HHS is not correcting the glucose, but rather correcting the anion gap. In patients with DKA, your anion gap must close. It must normalize. Your pH must normalize. Your bicarbonate must be greater than 18 and your patient must be able to eat. Whereas in HHS, your serum osmolality must be less than 320. So these are the two parameters that you actually need to hit in order to say, you know what, I have successfully managed and treated my patient with DKA and HHS. It's not so much the glucose level. So what happens is when your blood glucose level starts to drop and when you have not really reached your end point of the completion of treatment of DKA or HHS, you need to add sugar to your fluid so you can continue your treatment until you reach that end point. So at what level would you actually add sugar to your fluid? It's pretty simple to remember, guys. For patient with DKA, the moment your blood glucose comes below 200, you will add D5. Now your fluid is going to become D5NS or D5 half NS. That's it. So moment it comes below 200 in a patient with DKA, you will add sugar to your fluid. Whereas a patient with HHS, the moment it drops below 300, you will add glucose to your fluid. And your target glucose level until your anion gap closes in DKA and your serum osmolality normalizes in HHS. In a patient with DKA, you want to maintain your glucose between 150 and 200. Whereas a patient with HHS, you want to maintain your blood glucose between 250 to 300 until your serum osmolality normalizes. There you go, guys. That is it. It is so simple that your IV fluids is actually, you want to see it as a cocktail. I always tell my residents, when you take this cocktail and you want to mix a cocktail for the patient, which is going to be hanging, these are the three things you must look at: sodium, potassium and glucose. And that completes the section on IV fluids, guys. Alright guys, so now let's go on to the second most important step of management of your patient in your ICU for DKA and HHS, which is going to be your insulin drip. And your insulin drip is going to be intravenous, guys. IV insulin drip. So the big question for you guys as a resident when you're in your third year in your ICU rotation, when no attending is around, you need to start your patient on an insulin drip. What is the dose, guys? What is the dose? The dose is very, very simple. Here's either one of two methods you could use. You can either use a 0.1 unit or you could do 0.14 unit. The only difference if you choose 0.1 unit is you're going to give a bolus followed by the infusion. But if you use a 0.14 unit, at that point you avoid the bolus. It's pretty straightforward. So I want to put this into an actual patient perspective to you. So if I use 0.1 unit per kilogram as a bolus, if somebody was 70 kilograms, it's going to be 0.1 unit times 70 is going to give you 7 units. So I would give 7 units first off as a bolus. And once my bolus is complete, I will give 0.1 unit per kilogram per hour. So if it's a 70 kilogram person, it's going to be 7 units per hour as a drip. So once I started the patient on IV insulin drip, I must have a target. And my target should be to decrease your blood glucose level by 50 to 70 milligrams per deciliter per hour. So your drop must be about 50 to 70. If you hit your target all and well, you can continue the same drip rate until the patient's anion gap actually closes and all of the parameters have also normalized and you're ready to bridge your patient. So until you get to that point, you need to continue your insulin drip. And when you're considering insulin drip, your target drop of blood glucose per hour, it needs to be 50 to 70 milligram per deciliter per hour. What if you did not hit this mark? What if you did not drop by 50 to 70? Well, it's simple. Go up on your insulin drip. Go to 0.2. And after 1 more hour, if it doesn't improve, go to 0.3 and then 0.4. You can keep going up until you get your desired drop in your blood glucose level. So that's it. Your insulin drip rate is pretty straightforward, guys. You're normally going to use about 0.1 unit per kilogram per hour, and your target is going to be about 50 to 70 decrement in your glucose level. And if you do not hit your target, go up on your insulin drip. And the final piece of the insulin drip story is, when your patient's blood glucose level in a person with DKA drops below 200, at this point you need to decrease your insulin drip rate. Again, as I reminded you before, the target we are trying to reach in a patient with DKA is closure of anion gap, improvement in bicarbonate level, improvement in pH, and the patient is able to eat. Whereas the HHS patient was improvement in serum osmolality and patient is able to eat. So until I get to my target, I still need to continue my insulin drip. So what I'm going to do, the moment the blood glucose level drops below 200 in a DKA patient or a little below 300 in an HHS patient, I will drop my insulin rate to 0.02 to 0.05 units per kilogram of body weight per hour. So I'm going to decrease my insulin rate and I will continue my IV fluids, I will continue my insulin drip until I reach my desired endpoint at which I will bridge my patient. Alright guys, so finally let's come to the final piece of the puzzle, right? So when you're thinking about a patient with diabetic ketoacidosis, clearly they can go into severe acidosis. So the real big question is, at what level of pH would you give the patient bicarb? The magic number is going to be 6.9. Guys, when your pH comes below 6.9, you need to give them bicarbonate, and the dose of bicarbonate to be given is 100 millimolar in 400 ml of water, and you will see that most times you need to add 20 milliequivalents of potassium chloride to this mixture. The reason you're adding potassium is, when you correct an acidosis too fast, oftentimes this will also lead to a drop in your potassium level. You will cause sudden shift of potassium into your cells, which could lead to fatal cardiac arrhythmias. Therefore, you need to add potassium chloride to your bicarbonate pushes when you have decided to give your patient bicarbonate. So the important thing to remember is, when your pH goes below 6.9, you need to give your patient bicarbonate. Remember, it is not the same number in your septic shock patient. Septic shock patient was 7.1, whereas DKA is 6.9. Alright guys, now that you've actually mastered the art of managing DKA and HHS with your IV fluids as well as your insulin drip, we can go ahead and talk about what you're going to follow in your patients in your ICU. Number one, you're going to get a finger stick glucose every 1 hourly. The reason you're checking your finger stick every 1 hourly is for 3 important reasons. Number one, you want to see if you're attaining your target decrement of glucose, which is 50 to 70. Number two, once your blood glucose touches 200 in DKA and 300 in HHS, you have to add D5 to your IV fluids, and you also need to drop your insulin drip rate to 0.02 to 0.05 units per kilogram of body weight per hour. Alright, so that's the important reason you're actually doing your finger stick every 1 hourly. Let's move on to a few other labs that you're going to get every 2 to 4 hourly. You're going to get a venous blood gas because you're looking at your pH as well as your bicarbonate to see if you're headed in the right direction and are you ready to bridge your patient. you're going to get a BNP, which is a basic metabolic panel, and you're essentially looking for your sodium, bicarbonate and chloride. The reason these three is piled up together is this is how you calculate your anion gap. Your normal anion gap is calculated as sodium minus bicarbonate plus chloride. If you do the math, you'll realize the normal anion gap is about 10 plus or minus 2. If you see patients with DKA, they normally come with a very wide anion gap, and the eventual resolution of DKA is marked by the closure of your anion gap when it normalizes, essentially meaning it must be less than 12. Alright, last but not least, you are also going to get a serum osmolality level, because in patient with HHS, your target serum osmolality in order for you to bridge must be less than 320. So you're going to get your finger sticks every 1 hourly, whereas you're going to do a venous blood gas, a BMP to calculate your anion gap, and your serum osmolality every 2 to 4 hourly. And that's it. This is how you're going to monitor the progress of your treatment of your patient. Alright guys, so this brings us the final section where you're actually going to say, you know what, I have completed my treatment of my patient with DKA and HHS. So the final step is simple. The final step is, when do you think your patient's DKA has actually resolved? The resolution of DKA is marked by the closure of the anion gap. Okay, so once your anion gap is closed, that is one important parameter that you have met. Number 2, a normal bicarbonate level. Again, the acidosis has to correct, and your bicarbonate, when it becomes greater than 18, you can check this off as well. Number 3 is your pH. Your pH needs to be greater than 7.3. Once these 3 parameters are met and your patient can eat and the patient appears comfortable, at this point you will bridge your patient. Whereas a patient with HHS, essentially what you're looking for is a normalization of your serum osmolality. Your serum osmolality needs to be below 320. Once you hit that mark and your patient can eat, there you go. You have now resolved your HHS as well. So at this point is the big question, how are you going to bridge your patient? Bridging essentially means now you're going to give subcutaneous insulin to your patient and stop your IV insulin. But the thing is, both of them cannot happen simultaneously. That's the reason they call it a bridging, because there is going to be an overlap, guys. So this is how we're going to do this. So when you look at your patient, for instance, at 10 a.m. on a Monday morning, you notice that your patient's DKA and HHS has resolved. At this point, you will give your patient subcutaneous insulin. And how do you calculate the dose? If somebody is insulin naive, which means they have not been on insulin prior to this presentation, you will calculate your dose as a 0.5 to 0.8 units per kilogram of body weight. If you're using a 70 kilogram person, if you do 0.5 times 70 kilograms, it's going to be 35 units. So you'll give about 35 units at 10 a.m. But one important thing I want you to notice up here is the IV insulin continues to run all the way till 12 p.m. At 12 p.m. you will stop your IV insulin. However, if your patient has been on insulin prior to coming into the hospital, you could just start the patient's home dose of long-acting insulin at 10 a.m. and that's it. That basically completes your management of DKA and HHS, and you have successfully mastered the art of managing DKA and HHS. So this completes the section of DKA and HHS. This is just the first of many more videos to come in your ICU series. Once I'm done with the ICU series, you guys are going to be rock stars in your ICU rotation. Also, please don't forget to subscribe and hit the bell button so you will receive notification when we release the next video. Also, please don't forget to leave a comment below, as we love reading what you guys think about these videos. I hope you guys enjoyed this video. The purpose of this video to keep it as complete as possible, and every other section I'm going to be doing is going to be as complete as this as well. So stay tuned for more videos, and I'll see you guys on the next one.